Hello, everyone. Thank you for joining us today. I'm Kelly Lance, and Debbie Parrott is here with me as well. And we have with us today Dr. John Urse. Dr. Urse is with Orthopedic Associates of Southwest Ohio. He was supposed to be live with us at the Franciscan Center a few months ago, but due to the COVID-19, we've had to, as you know, cancel all of our events. So he has invited us into his boardroom today. We allowed him not to wear a mask because we have safe distancing here, and you'll be able to hear him much better that way. Dr. Urse, thank you for being here with us. We hope to have you live at St. Leonard soon, but in the meantime, thank you for agreeing to meet us in your boardroom today.
Well, thanks, Kathy, and thanks, Debbie, for coming over. We've all got to make a few concessions now with the environment we're in with some of the virus protection concepts. So I'm happy to be here, and actually I got to stop seeing patients in order to do this, so
Well, thank
happy.
you.
So I thought what I'd do is talk a little bit about what we see most commonly in an orthopedic office, and that's wear and tear arthritis and some of the things that cause the most disability problems in the United States. There are things like heart disease and cancer and stroke that actually kill people, but the things that disable people the most are arthritis. And so there are things that hurt our knees, our shoulders, our hips, that keep us from getting in and out of a car or getting out of the bed or going to watch our family's soccer games. And those things are what really bother people on a regular basis. They disable us. So my job as a orthopedic surgeon is to talk to people about what they can do and try to do those things that get them to age 90 or further based on your genetics with the body parts we have, because they're the only parts we have, right? We're a lot like car engines. We kind of got to run those like the people in Cuba. We got to keep them going. And they're still running down there, and a lot of people here are living longer, and we just want to live better longer. So what I tell my patients is, let's come in and have what's called an exam, where we talk about how you look on your body part, your knee, your shoulder, your hip, and we'll examine that body part to see how it moves, how much strength the muscles have. But the other thing we'll do is we'll take an x-ray. So if I show you an x-ray of a normal knee, I think you can see there's a space between the bones, because the spaces between bones are filled with cartilage. Cartilage is the white stuff at the end of a chicken bone. Some people call it gristle. But when that wears down or softens, you've heard the word chondromalacia, that means soft cartilage. So as that cartilage wears down, then the bones start to get closer together and they can actually rub on each other. So on this picture of an arthritic knee, we see that the bones are starting to rub on bone, and when a doctor shows you that, they may say, oh, you've got bad arthritis. Well, you already knew that, you're the one that's limping. So I tell people, my job is to give you what are some options that either slow the progression of the arthritis, delay having to have a knee or hip replacement or shoulder replacement, and give you some safe options that don't make the condition worse. And when I say worse, there are things that actually are not good for you. Things like anti-inflammatory medications, Motrin, Aleve, all those are great for a short-term headache problem, but they're not good long-term for your body. Those anti-inflammatory medications affect the stomach. We can have bleeding ulcers. They affect the kidneys or the liver. So long-term use of those are not great options. For arthritis, there are some better things that control pain. One of the things would be Tylenol, which is acetaminophen, very safe medication, doesn't hurt the stomach or the kidneys. You can't take more than 4 grams a day, that's 4,000 milligrams, but gosh, you can pretty much take a good amount of that and get good relief with a simple medicine like that. But there are other things that are natural anti-inflammatory factors. Back in the 90s, I was on George Bush's White House Committee for Alternative Medicine. So alternative medicine means, would things like acupuncture help? Would some of these herbal remedies help? And the answer is they do. They are alternatives, they're safe alternatives. And I tell my patients, you may want to look up what are called natural remedies that help control pain and inflammation. So if you're going to take notes at home, here's some of the things to write down. You may have heard of turmeric or curcumin. These both come from the curry plant. It's a spice we use in cooking. The problem with turmeric is it isn't taken up by the gut very well. So only about 3% of its content is taken up in the gut. Curcumin is more active. It's a better form of that. And if you add black pepper extract, it's called bioperine, you increase the uptake of curcumin by 2,000%. So that's really good. So you could probably go on Amazon or go to a health store and say, I want to get some curcumin with black pepper extract. That's a nice alternative for controlling inflammation and pain. The other things that you may have heard of are called fish oils or flaxseed oils. Those are things you may check with your doctors. They do have a little bit of blood thinning potential. So if you're on a blood thinner, you want to check any of these medications with your doctor first. But I always tell people 2 tablespoons of flaxseed a day works really well for some of the joints in the fingers or the toes. They do help some of the larger joints. Flaxseed oil tastes like cod liver oil from your grandma. Doesn't taste that great, so I put mine in applesauce. Anything can be tolerated in applesauce. And then one or the other. You don't need a fish oil and a flaxseed oil. But the other thing that's really good is Boswellia. And Boswellia comes from actually a bark of a tree where we get frankincense. So if you remember the wise men, they were pretty smart. And boswellic acids are the derivatives of these natural anti-inflammatories. And when you do a double-blind study between medicines like Celebrex and Boswellia, they both actually have about the same benefit, which is good, without the side effects of the stomach or heart or kidneys. So those are some natural things that help control pain and inflammation, and certainly are good long-term options for arthritis. You're certainly welcome to use topical creams. I don't care if you use CBD oils or anything that's legal or illegal. It doesn't matter. It's not coming from me. And whatever helps you, you know pretty quickly if it works or not. There are some pain patches. I think some of the Voltaren gels are now topical creams that can help with arthritis discomfort. So then let's talk now about things beyond what you can do on your own and what I can do for you. So there are types of injections that help pain. We can inject cortisone. Cortisone is fast acting, but it's not very long lasting. The next type of shots that is really only approved by the FDA for knees are the gel shots. They call them viscosupplements, and those are literally like WD-40 that we put in as a cushioning gel in your knee, and they can last up to 6 months. They are approved by insurances. Most of the insurance, a couple of them, Anthem doesn't pay for those, at least in the certain under 65 age group. If you're older, there might be an advantage there. And then there are other types of injections. There's what are called biologics, where we use your own biology or your own blood. Things like PRP, which is platelet-rich plasma. That's taken from a simple blood draw in your arm. They draw about 10 or 15 cc's of blood, spin it in a little concentrating device called a centrifuge, and then we inject it in your knee or shoulder. That's good for mild problems. It's not for real bad knee or hip problems. For more severe problems, the better biologic answer is your own body's stem cells. And stem cells come from bone marrow. There are other places you can get stem cells. There are fetal sources from a placenta of a C-section baby. The problem with that is it's somebody else's tissue, so there's some reactivity between different people that way. But they're also dead cells. They're coming from something being put in a freezer, packaged in a factory, put in a traveling salesman's trunk, and taken to someone's office where they then get put into you. And if you look under a microscope, they're not living cells. So they are truly what are called stem cells, but they're not very biologically active. They have a little more what's called anti-inflammatory properties for pain, but for the price they charge, you're probably better off with your own blood called PRP, which have just as many of the anti-inflammatory properties. The advantage of a stem cell over PRP is that stem cells can help with cartilage growth, and cartilage is the stuff we talked about that wears down in the joints. Now, the thing everybody's thinking is my x-ray going to go from this back to this if I get a stem cell injection? And the answer is it may not, and it may never. But it should, over time, grow cartilage over the 6 to 12 month period. And we don't know how much it'll grow, but we do know that the studies where they do an MRI of your knee 3, 6, and 12 months after a stem cell injection, not a lot of cartilage growth occurs in the first 12 months, but after that, most people have some, either by MRI or if we do what's called a second look arthroscopy or a look into the joint. So the advantages of stem cells are twofold. Short-term advantages, they have tremendous anti-inflammatory and pain control properties that really help that unhappy hip, knee, or shoulder, or ankle, or other body part. But the second thing is the building blocks, like the cartilage growth factors that come later. So what you want to do is do your homework on any of these what are called biologic products, no matter where you get them. And if someone says, I like to take them from your fat of your stomach or from a amniotic source called an embryo or a placenta of a C-section baby, I would ask to see some of the articles or the literature that supports those have worked, because I haven't seen many, but there are some on my website. If you go to drjohnurse.com, there is a blog section that has article reviews where you can see where some of the bone marrow sources using your own bone marrow actually have shown some benefits to people with arthritic problems. So those are a couple ways to help your problem or to slow progression. You may have also heard of chondroitin and glucosamine. Those are building blocks for cartilage. So if you said, well, can those help my joints? There's some pretty good studies on chondroitin helping the small joints of the hand. Glucosamine, if it's a good brand, and there's a lot of lousy brands out there once you start getting into the nutrition and vitamin departments. A good brand glucosamine can slow arthritis progression in the knee. And what that means is, let's say instead of having bone on bone, you've only got about half the joint narrowed, not completely narrowed. If you take a good brand glucosamine, there's some studies out of Belgium that show people with a good brand glucosamine have no progression of their arthritis over 3 years on x-rays versus someone who didn't take anything and theirs got worse. So those are safe things. The downside of glucosamine and chondroitin, glucosamine comes from the shell of a shellfish. So if you have a shellfish allergy, you don't want to take glucosamine. There may be a few shellfish-free brands, but there's not very many. And if you're a vegan or you have some issue with bovine cartilage, that's where the chondroitin comes from. So there are some theoretical disadvantages of some of these nutrition products. And the only other thing I would tell you about the stem cells that we spoke about is that we do those in 2 locations. We take them from the back of your pelvis, and we either do that in the office where you take a relaxing medication like a Valium or an Ativan, someone drives you in, we numb up an area on the back, we draw the stem cells and spin them, and we put them in your hip, knee, or ankle using an ultrasound. The other option you have is to have it done at the hospital, where the anesthesia doctors can give you some Lala juice in your IV, and you can have your heart monitored to watch for any issues with that. As we get older, sometimes that's a safer way to do it. And we will see some of the insurances are paying part of that, and actually some of the secondary carriers for Medicare are pretty open to that now. I wouldn't say you should rely on that as a definitive way to get it done, but as we look at the cost of a joint replacement, which is in the $50,000 to $70,000 range, and the cost of a stem cell, which is under $5,000 and really under $4,000 in some cases, those things at some point I think are going to be more attractive to the insurance industry or the healthcare industry as a way to postpone joint replacement surgery. And I tell people these things may never avoid the need for it, but they certainly may delay it. Or if you've been told, hey, I'm too old, or my heart's too weak, or I'm too young, or I just don't want surgery now. These are nice options to look at to postpone or delay surgery. The other things that help arthritic joints are simple things like physical therapy and activity. So when we say motion is lotion, we mean you've got great facilities there at St. Leonard's that'll help with keeping you active. And we know that, motion lubricates the joints. And even though you may have more pain with an impaction type activity like, a treadmill or something. There are gazelles or swimming or just walking on good surfaces that keep activity and flexibility in joints. And we want to maintain 2 things. We want to maintain joint lubrication and motion, but we also want to stimulate our bones. We know that when we load bones, the bones get stronger, and there are the converse is someone who never walks, never moves, the bones get weaker. And then weaker bones lead to osteoporosis. That can lead to fractures in the hip or back or wrist or places you don't want them. And that's not good. So, I know that they emphasize, joint health and nutrition with vitamin D, calcium, citrical, and even sunshine. Sunshine is what gets you vitamin D production in your body. So even sitting out on, a patio for 15 to 20 minutes a day gives you sunshine, and it does a lot of things. It helps your mental status. It helps your bone mineralization. It helps make vitamin D for your body, which helps make calcium, which helps your bones. So it's a cascade effect and a benefit to maintaining activities and whatever it is. Whether you're looking at birds or looking at flowers or walking around, just seeing the things in nature. So you've got a nice campus there. You can use it, outside when the weather permits, and then I'm sure there's indoor facilities or some water therapy options, even for some of the more painful joints. And even if you don't swim, you can go on the shallow end and wiggle your toes. Mm-hmm. So the other things I would tell you, there are some other ways to help, things like knees or ankles or foot problems that have to do with braces or arch supports or little wedges in the shoe, and they kind of balance your leg, and that can help your knee, your ankle, your hip, and even your low back. I mean, my brother's an anesthesia doctor in Michigan, back pain for 20 years. He put good arch supports in his shoes, and his back pain went away. He says, like, what's going on here? It's like, who cares? Whatever you're doing, if you think of a coffee table with 4 legs, if one of those legs is uneven, what do? You stick a few napkins under one, and all of a sudden it's better balanced. Well, sometimes that happens with, one leg being a little longer or the pelvis is off a little. So I think that, you may want to ask your therapist or ask your some of your physicians or advisors, what are the other those are called low-hanging fruits. You put a cookie in your shoe, or you put a little knee brace on and you go for a walk, and that takes a bowed knee and makes it a little straighter. So what we try to do in our practice at Orthopedic Associates is we like to give people all these options, and then they tell us, I've already done therapy, or gee, I haven't done any therapy. I haven't tried this, or I haven't tried that. What we don't want to do is have you take things that are going to cause you some problems down the road. And right now in the United States, more people go to emergency rooms with serious GI complications from anti-inflammatories than the AIDS virus right now. So there's nobody marching on Washington saying no more Advil, okay? But maybe we should save the Advil for a bad headache and not be on those things long term for knees or shoulders. So I like to give people those safe options. I think we have a lot of new, what are called emerging technologies now. These are things that are, and I call them cutting edge technologies, because beyond 5 years ago, we didn't have PRP or stem cells. They were done mostly in Europe. My wife actually had a pretty painful hip 5 years ago, and she asked me, why don't you guys find something that grows cartilage? And I said, well, nothing grows cartilage. She said, well, they're putting stem cells in people in Europe. I said, well, let's go. Where is it? And they said, Bologna, Italy is having good success with stem cells. I said, well, I'm Italian. Let's go to Italy. And the first class in North America was in Naples, Florida, almost 5 years ago. And I went to that, and it was the first time we heard about stem cells in PRP. And unfortunately, at the same time, my wife's hip was not doing too well, and I was smart enough to decide not to deal with that. So I took her to another orthopedic guy. He goes, yep, you need a new hip. And she said, thank you, but no thank you. And 4 years ago, I put stem cells in my own wife's hip. She was one of my earliest patients. She still hasn't had her hip replaced. She knows she's going to need it done someday. But for her, it was a great option. She was younger than she wanted to be for a hip replacement. And she thought the longer she could delay that, whenever she decides to do it, it may then last longer and hopefully not have to be redone. So for her, it was a great option. And when people ask me if these things work, I said, well, I'm sleeping with something that, I think I'd know pretty quickly if it didn't help. So a lot of times we do what are called outcome scores for people. We say, well, your knee is bothering you. Fill out this form. Tell me how you do with everyday activities. It's called a pain and function score. And then after you've had stem cells or PRP, we give you that same little scoring sheet 3 months, 6 months, or 12 months later. So the last 140 stem cells I've done for knee problems, all but 2 people have had better scores at 3, 6, and 12 months. And those are things in one of the blog articles I have on my website that you can look at. But we do try to benchmark things, so we don't just say, oh, my doctor said I'm doing great. It's like, he didn't ask me, I'm not doing so well. So when the patients fill these forms out for their hip or shoulder or back, that usually tells you they're filling out the same information they had before it. So I think that gives us a good way to gauge what I think they're telling us it's doing for them. So the downside of some of these biologics, I call it, is financial misery. There's some cost, and I think at some point those costs compared to some of the procedures like a knee replacement or a joint replacement are really minimal in the big scheme of things. It's just not a conventional way that everybody's looking at things. But everybody's had a few athletes or a few articles they've seen on TV with somebody. I mean, for instance, Jack Nicklaus went to Munich, Germany to have stem cells put in his back. And there are some people that do some of the spine. We didn't talk much about back arthritis, but spine is a newer area that they're putting some of the biologics in. So I think people should, do their homework, kick the tires, look at some of these options when they have problems and say, is what I'm doing helping me? If it's not, maybe I should look at some other safe options.
Can you walk someone through what it would be like to get stem cells if I came in your office for the procedure? What would the steps be?
Sure. Well, that's a good question, Kathy. The first thing we do is that wouldn't be the first time I've seen you. You would come in the first time and I would talk to you about your x-rays, talk to you about your options and say, here's something I think we could do. I'd give you the option of doing it in the office or the hospital and say, look, maybe you feel better not feeling anything, having, some, we call it la-la juice, but whatever anesthesia does to make you happy. And then we would talk about that first. There's other people who live further away and we'll do a telemedicine call and we'll just say, oh, you're in, like I had a lady Monday who came from Indianapolis and we talked to her first. She sent her x-rays and I said, gee, you don't have to come all the way here to show me you got lousy x-rays. There are a couple things I caution people about. Some of the cholesterol medicines are bad for stem cells, so we'd want to stop those for 3 weeks before you come in for a stem cell. So if we're going to walk through that day, what you're going to do, Kathy, is you're going to ask Debbie to give you a ride, because I'm going to give you a Valium or something to make you a little relaxed about an hour before the procedure. Yeah, I mean, why not? You're not driving. So if you come in, what we do, we tell you to wear loose clothing. And then if you were on a blood thinner, we'd want to stop that 3 or 4 days ahead of time. And then we would have you clear that with your cardiologist or your doctor who has you on blood thinners to make sure it's okay to stop it. Then what we do is that day, if it's a stem cell, we have you lay on your side and we numb up a small area on the back of the pelvis where there's a good amount of the stem cells in the bone marrow. That area gets some Novocaine, and when it's numb, we use an ultrasound to draw the stem cells out. You're going to feel pressure doing that, and maybe a little uncomfortable, but it's really not too bad. Most people feel very little discomfort even the next day. Once that is taken out, we take the blood and put it in a thing called a spinner device or centrifuge, and we just tell you to lay on your back for about 15 minutes if you're comfortable, because that's how long it takes to separate the good part of the blood from the bad part. We don't want white cells or red cells in your knee. They're bad for knees or shoulders or joints. But the stem cells and the platelets, we sometimes will draw blood at the same time from the arm and combine that with the stem cells to get a super injection for the joint. Once that's done, if it's a knee injection, we numb up a little area on the skin with Novocaine, and we inject the knee with the stem cells using an ultrasound to get in the place we need to go. Same thing with a shoulder or a hip or an ankle. After that, there's a little bandage on your back. There's a little Band-Aid on your knee. Most people walk out. We give you a couple pain pills if you need them. Most people don't need many. We really don't do much the first day or two after that. If you leave the office that day, you can shower the next day. We tell people not to be up more than about a half hour at a time the first day or two, and just start moving the joint, motion, flotion. We talked about that. The other thing is stem cells are very fragile, so we don't want to like smash them or compress them or twist them. So very few people do vigorous therapy after this. We just tell people start moving. Activities like a gazelle or a light treadmill or things like that are fine the next week, and then they gradually increase activities. I usually keep my golfers off for a month or two from real twisting and heavy torsional forces. If you're on the cholesterol medicines, you can start those a week later after the stem cells. We don't like Motrin and anti-inflammatories after the stem cells at all for at least 2 to 3 months, because your stem cells are anti-inflammatory in their function. So the medicines actually block some of the stem cell activity. So you don't need the Motrin or the other things at that point. So if we can stay off those, we prefer it. I always tell people if you get a bad headache and you want to take an Advil, it's okay. There is a few people that, and I would talk a little bit about what to expect afterwards. Most people feel better right away with stem cells because you get that anti-inflammatory effect of the proteins. And there's over 1,000 anti-inflammatory proteins in some of the platelets and stem cells. But afterwards, you may get some up and down days. And I tell people how that goes later is a little like a stock chart. So if you watch the stock market and you go, wow, up, down, you can get that variability, and it isn't always predictable. It may not be weather related or activity. You may not have an idea why one day is better than the other, but you certainly figure out, hey, I overdid it a little bit here and I need to take it easy. I will tell you, shoulders do the best, the fastest, because we don't walk on our shoulder like a hip or knee. Knees are next fastest in getting better, and hips seem to take a little longer to get better because it's a deeper joint, and it may take 3 to 6 months to see a benefit from a hip. Most people will get some quicker on motion and movement, maybe sleeping better at night, but again, every joint's a little different, every person's different. The other thing I would tell you is if you have let's say you're that 2 out of 140 people, or maybe you don't see the response in 2 or 3 months that you'd like to, some people get a booster shot of PRP, which is just the blood draw. Those are much more inexpensive than a stem cell. I don't ever routinely repeat the stem cell injections. So most people, if they don't really see much in that first 2 or 3 months, you can get a blood draw and we can stick some PRP in as a booster. That can be done once or twice if you just don't see the result you'd like. And then ultimately, we hope this is going to last for quite a while. It doesn't mean you wouldn't need to have your knee replaced someday or your hip replaced, but that's the purpose of what we try to do, is help slow progression or delay the need for major surgeries. Mm-hmm. And then occasionally we actually combine these stem cells with surgeries. Let's say you have a torn meniscus in your knee that's flipping around, or a loose piece, but you have some arthritis. Well, taking the loose piece out, the scope helps that part, but the arthritis part, you may want to have some PRP or stem cells done with your procedure. Now, my fees are lower with that because I'm already doing a surgery. The hospital's supplying a kit. Then you let the hospital and the insurance fight over who's paying for the kit and what they pay. And that's where some of those secondary plans are starting to pay for some of the biologics. On a day like this, on a Wednesday, if you went to Wright Pat Air Force Base, the military's doing 20 biologic injections today. And that's because the wait time for a knee replacement's probably years, and they know that they have to do something besides cortisone or gel to help people delay or get to their surgery days. So I think these technologies are newer. I think people should read a little bit about them. They may not be for everybody. They may not be affordable by everybody, but they are certainly something in the future that I think are going to change the way we do medicine.
I have a question. Is age a factor in bone marrow stem cell production? And then what can I do, if anything, to increase my stem cell production?
Well, you probably can't do much to increase your stem cell production because what you have actually does diminish with age. So somebody who's 32 years old has a higher stem cell concentration than someone who's 80. There's no doubt. There are some people who feel hips over age 65 don't do as well as other groups. And we said hips are slower anyway. But if you said, is there any downside to it? The answer is no. There really are benefits I've seen in those older groups. I'm not going to tell you my wife's age. So I will tell you,
Smart man.
What we don't know is how many stem cells do you really need to get a benefit. So if you said, well, I have 4,000 here from this age patient, or this many from fat, like 8,000 from fat, I mean, what if 2,000 is enough to really hit a benefit? That's what we don't know. I always use the fly on the wall analogy. You could say, well, I used a cannon and I killed the fly, but a newspaper could do the same thing and it's a lot less, and it did the job. So, I think that we concentrate, when you spin blood from the bone marrow, that gives a 12-fold concentration to the amount of what are called the stem cells and biologic cells we want. And the centrifuge separates the good and the bad cells from the ones into separate little chamber bags, they call it. And then that's the stuff we use to put in the area of problems.
Okay. I have another question. Are calcium supplements effective on their own, or should I take them with other supplements to increase their efficacy?
Well, you will get a benefit taking them with vitamin D, and the D3 is the easier absorbed form. Your body will always keep the blood calcium levels normal. Unfortunately, if you're not getting your normal amount of calcium, it'll start taking it out of bone, because bone stores 99% of the body's calcium. So what you need to do is you need to have 500 to 800 milligrams a day in your normal diet. You can supplement that with extra amounts if you're not eating well, and there's always a little more you need if you're pregnant, etc., or if you're healing a fracture. So most people will do well with I always call it a vitamin D and calcium supplement. There's a thing called CitraCal that's a pretty good option. And most of these are really good for bone health, along with just the simple things we talked about with loading the bone with activity and walking, and like literally they actually have some of those. You've seen those little single trampolines that you hold the bar and just kind of hop on a trampoline like a kangaroo. That's really useful for bones. I mean, it's got to be safe doing it. Can't be dizzy.
How much exercise should I be doing to the point of stress but not injury?
Well, that has to do with how sore your knee might be. So what I tell people on activities, let's say you have a problem, or you've had surgery for a problem, or you're recovering from surgery for a problem. My rules of the road are this. If you said, I'm going to go out, I'm going to start walking my dog, or I'm walking with my spouse after dinner, and we're going to go 2 miles. The next day you go, I'm a little sore. It's like, well, let me tell you, I haven't been walking much, have you? So as we start new activities, it's normal to be a little sore the next day. That's okay. Then you can gradually increase it. Let's look at going 4 miles with your dog or your spouse the first day. The next day you can't even move. Well, you way overdid it, right? So at that point, you need to cut back and you need to rest for a day. And if it hurts while you're doing it, if you said, boy, I'm like, my knee's killing me and I'm trying to do what this guy said, then you're doing too much too soon. You need to rest for a couple days and say, look, I need something else. Your body's telling you it's too soon to be doing what you're doing. So, I mean, those are not hard fast, but they're pretty easy to see that if you do a little bit and you're not bad, do a little bit more. I always tell people, walk your dog 5 blocks, and then if you're fine, go 10 blocks. But don't start off with 3 miles the first day. I mean, the poor dog's going to be tired too.
Anything else?
Well,
thank you very much.
You're welcome, even more. We'll do this one day at the center with some slides and some pictures. We only used one prompt today, but like I said, I think that gives people a chance to do some homework, get your questions. I would tell you if you're thinking of coming whenever we reschedule it, get in early. We were here last year, and I think we filled up pretty quickly, and I think we need a assembly hall of sorts.
That's right. And
Or
now we
maybe
have
we'll-
to social distance, so we have less room.
Yeah, well, whatever. So maybe we just try to use some of these other ideas with, video conferencing.
Well, thank you very much for your time.
Thank you.
Thank you.